Bismillahirrahmanirrahim. So the first topic of nephrotic syndrome is membranous nephropathy. Membranous nephropathy is one of the most common cause of nephrotic syndrome in adults. It is characterized by the diffuse thickening of glomerular capillaries, which is due to the deposition of immune complexes in the glomerular capillaries and subepithelial side of basement membrane. Membranous nephropathy can be either primary or secondary. 75% cases of membranous nephropathy are primary, which means that the cause of the disease lies within the kidneys. The secondary cases constitute almost 25%, which means there is a systemic identifiable cause of the disease. Coming on towards the pathogenesis of primary membranous nephropathy. So there is phospholipase A2 receptor, which is present on the podocytes and acts as an antigen. So specific type of IgG antibodies known as IgG4 autoantibodies are formed and immune complexes are deposited, which activate the complement system, resulting in release of proteases and oxidants from endothelial and mesangial cells, resulting in damage of the podocytes' food processes. IgG4 autoantibodies are different in a way that they do not recruit the inflammatory cells. Rather, the damage is caused by the proteases and oxidants released from endothelial and mesangial cells. So there is paucity of inflammatory cells. The damage to the food processes results in increased protein leakage into the urinary space and result in proteinuria. So the antigens in secondary membranous nephropathy can be either endogenous, such as in SLE and other autoimmune diseases, or they can be exogenous, such as in certain infections. So immune complexes are deposited in the subepithelial side of glomerular basement membrane, which activate the complement system and damage the food processes of the podocytes, causing proteinuria. So what are the causes of secondary membranous nephropathy? The most common is certain drugs such as gold salts, certain NSAIDs, and penicillamine. All these drugs are used in the treatment of rheumatic arthritis. Certain malignant tumors such as colon cancers and lung cancer are also identified to be the cause of membranous nephropathy. Then there is systemic lupus erythematosus, and certain infections such as hepatitis B virus infection, malaria, and treponema can also cause secondary membranous nephropathy. Autoimmune diseases such as diabetes mellitus and thyroiditis can also cause membranous nephropathy. So the histological picture reveals thickening of the glomerular capillary walls due to deposition of immune complexes. As you can see in the diagram, there is thickening of glomerular capillary walls. In the late stage of the disease, glomerular sclerosis can also occur. The immune complexes damage the food processes of the podocytes, so there is effacement of the food processes. And the typical feature of membranous nephropathy on histology is dome and spike pattern thickening of glomerular basement membrane, which is seen on silver staining. So this is glomerular basement membrane, and these are immune complexes deposited on the GBM. So GBM material is laid down between the immune complexes, giving a spike-like thickness to the GBM. So these are the spikes. What happens over the time is that this thickness increases and the spikes change into a dome-like appearance, embedding the immune complexes within them. So these spikes and domes appear protruding from the GBM. So this is a dome and this is a spike. This dome and spike pattern thickening of GBM is only seen on silver staining. One more thing you need to remember is that there is absence of inflammatory cells in membranous nephropathy. As you can see here in the diagram, there are no inflammatory cells seen. Electron microscopy reveals dense humps of immune complexes present in the GBM and subepithelial side of glomerular basement membrane. Immunofluorescence microscopy reveals granular deposition of immune complexes, which is also present in post-streptococcal glomerulonephritis. As you may recall, granular deposition is also present in immune complex mediated rapid progressive glomerulonephritis, whereas in anti-GBM antibody mediated RPGN there is linear deposition of immune complexes. So membranous nephropathy typically presents with the signs of nephrotic syndromes, which include edema, swelling, proteinuria greater than 3.5 grams per day, hyperlipidemia. There might be bleeding disorders and presence of infections. In some cases, there is hematuria and hypertension. A causative disease such as any autoimmune disease or SLE might be present in case of secondary membranous nephropathy. Renal function tests denote the functioning of the kidneys, and the diagnosis is established on proteinuria greater than 3.5 grams per day, and the definite diagnosis is based on histopathological studies of the biopsy. Treatment is with steroids and cytotoxic agents, whereas in the advanced disease, renal transplant can also be needed. So to understand the concept better, a 32-year-old male presented with the generalized edema and hematuria. Test reveal proteinuria 4.2 grams per day, which is in the nephrotic range. Systemic examination reveals swan neck deformity of right hand phalanx. So what is swan neck deformity? Swan neck deformity is a typical feature of rheumatoid arthritis. So let's say this is proximal phalanx, this is middle phalanx, and this is distal phalanx. This is the normal appearance. So what happens in rheumatoid arthritis is that this is proximal phalanx, this is middle phalanx, and this is distal phalanx. There is flexion of distal interphalangeal joint. So swan neck deformity is a typical feature of rheumatoid arthritis. The drugs commonly used for the treatment of rheumatoid arthritis include NSAIDs, gold salts, and penicillamine. So these drugs are known to cause secondary membranous nephropathy. So what is your provisional diagnosis? Provisional diagnosis is secondary membranous nephropathy. What specific pattern will you look for in histopathology? The specific pattern of membranous nephropathy is spike and dome pattern thickening of glomerular basement membrane. What is the common antigen in primary membranous nephropathy? The common antigen in primary membranous nephropathy is phospholipase A2 receptor, which is present on podocytes. So that brings us to the end of discussion. If you have any questions, do let us know in the comment section. Thank you.